My name is Michael Geffin. I'm part of Greater Boston Urology. I'm the Chief Medical Officer, as well as the Director of Advanced Prostate Cancer Care here for the group. So screening for men varies. There are many guidelines in general. Most men will start screening at age 50. Essentially, the first line involves two tests. One is what's called the digital rectal examination. That's essentially, as men know, that's a physical examination through the rectum where the primary care doctor or the urologist, if they're being screened in a urologist's office, will palpate the prostate to feel the area near the rectum. The second part of screening involves the PSA. So PSA is a blood test. It is a protein which is eluted by the prostate. It can be elevated for reasons of prostate cancer cells, making more of the protein and putting it into the bloodstream. There are other reasons why PSA can be elevated as well. So really part of the screening of prostate cancer with the PSA is to parse out whether the elevated PSA is due to a more likely malignant disease or more likely due to a benign disease. So standard care for treatment involves multiple options depending again on the individual, the prostate cancer. They could be led to either having surgery, radiation, which there are a number of forms. Some men opt for watchful waiting and doing nothing. There are newer therapies on the horizon. High-intensity frequency ultrasound, which is a heating therapy of the prostate to kill the cells. We also have cryotherapy. Those are all methods for treatments and their standards. Those are the standards of care. There are pitfalls with PSAs. PSAs, as we noted, that can be elevated for non-malignant reasons. So a lot of those men will be referred to a urologist to see if the elevated PSA is more likely due to a cancerous reason or a non-cancerous reason. We have other testing which we can use as well before the individual would undergo a prostate biopsy. The standard of care had been very much to do a biopsy in any man who has a PSA above 4 who has a survival of 10 years or greater, but that's clearly shifting with these other tests because they're very helpful in letting us know who not to biopsy. We have a lot of options here and tests at our disposal, which other places may or may not have. We can use a blood test called the 4K score, looking to see what's the chances the individual has prostate cancer before a biopsy. Or the 4K score most likely tells if a patient has high-risk prostate cancer. There is Select MDX, which is a urine test that helps parse out whether a patient does not have prostate cancer. It answers the question, what's the likelihood this individual does not have prostate cancer? Another urine test, which we have available here, is called Exosome. It answers a similar question. We're the only lab in Massachusetts which has this test. It's a more sensitive test on whether the elevated PSA is due to prostate cancer or not. It's a very key piece in helping us determine whether someone needs a biopsy or not. And many times when someone has an elevated PSA and a Phi score, which indicates they have a very low risk of prostate cancer, many of those men opt not to have a biopsy, and that would be absolutely correct because we would have historically biopsied all those men. With prostate cancer, we definitely can change the course of the disease by screening men early and often. If they get treated early, their long-term survival will be impacted in a positive way.